Today our lecture will be USMLE Step 2 CK Hematology Part 10, and we will discuss about sickle cell disease. And I am producing this lecture for the medical students who are doing their rotation, and in their leisure time they can listen the lecture. I am giving the broadly discuss about this, so it will be not like high yield. It will be everything you know you need to know to do very well in USMLE Step 2 CK. So hope anyone will listen 1 or 2 3 times. After then that same time they will read their book and they will understand it better, and hope within 6-7 months will be most someone need to prepare for USMLE Step 2 CK. And after know my book, my lecture, and to the question, if you are doing well, you are ready for exam. And my lecture is to prepare you to do well in the question, and the question will give you hints that are you ready for the exam or not. So today I am going to talk about the sickle cell disease. So it is a big lecture, so I think I have to do it in 2 videos. So I will, in part 10 it will be half, only you will see the part 11 also talking about the sickle cell disease. So what is sickle cell disease? What is causing it? Is a genetic disease. Is autosomal recessive disease. So what is autosomal recessive disease? Both pair of gene is missing, and sickle cell disease can cause the chronic hemolytic anemia. And because it is a sickle cell, it is a genetic disease, is a disease in the hemoglobin. So we call it hemoglobinopathy. So sickle cell disease is a hemoglobinopathy. So this, when you know this one, this will be help you to confirm the diagnosis of the sickle cell disease, just to the electrophoresis, to know the gene. So this is a genetic disease. So usually most of the people who have sickle cell disease, they show their symptom very young age, like around the age of 6 months. So sickle cell disease is an autosomal recessive disease, and this person, like say a person is homozygous with the sickle cell disease, his both gene is missing, and this person become hypoxic, dehydrated, or infection going on, or he has acidosis, or he has a fever. His red blood cell become irreversibly sickle cell. We call the red blood cell precipitate. So even without any etiology, patient does not have hypoxia, no dehydration, no infection, no acidosis, no fever, and still this person can develop sickle cell disease. And what we talking about, hypoxia, dehydration, infection, acidosis, fever can cause the person with sickle cell disease to see the red blood cell to precipitate, and red blood cell will be sickle in cell the red blood cell will be shaped in like a sickle, like a and like a crescent moon shape. And when red blood cell become disc shape to like say crescent shape, it can occlude the blood vessel. We call it veno occlusion, and it can be on and off. So we call it intermittent veno occlusion. So when this happens, it occludes the blood vessel, so tissue will be hypoxic and it can develop acidosis, which can cause the painful crisis, and also it can cause the painful swollen extremity. And the person also can have chest pain, abdominal pain, lower back pain, pain at thigh, knee, and patient also could have fever. So any organ can be affected when sickleed red blood cell occlude the blood vessel and tissue become hypoxic. But most of the time it happens to the hand and feet. So initially or the beginning, so it can give the painful swollen extremity. So when sickle cell disease will be sickled, and it will go to the spleen will remove this cell, and this can cause his hemoglobin will be go down. But most of the case, probably if he had little amount of cell become sickleed person, hemoglobin, hematocrit will not go down. But if it be too many of them, then it can happen. So breaking down of the red blood cell in sickle cell disease usually not cause the hemoglobin to go down, but some other thing can cause hemoglobin to go very rapidly go down. I will talk about it later. So if sickle cell disease, for example, occlude the blood vessel partially, and blood vessel want to go through this, and it can cause the destruction of the red blood cell, and it can cause the indirect bilirubin to increase. And if a person have one episode now, and after that we give him treatment, we give him oxygen, we give him fluid, and he become normal again, it may possible he can have become dehydrated, has infection, acidosis, fever, or hypoxia, or no reason he can develop the same symptom again. So this is a chronic disease, and it can be on and off. So he could be symptomatic, and then he have asymptomatic, then he becomes symptomatic again, and he become asymptomatic again. And so he doesn't have pain, then after that he can develop painful crisis again. So sickle cell disease is a recurrent disease. So sickle cell disease can have hemoglobin hematocrit normal, or hemoglobin hematocrit could be low, and hemoglobin hematocrit become low gradually, or it can happen suddenly. So like say a sickle cell disease patient has hemolysis, and he has also glucose 6-phosphate dehydrogenase deficiency. Same time, he can develop gradually, his hemoglobin hematocrit can gradually go down, or person develop acute splenic sequestration. What is this one? Person has sickle cell, and this sickle cell, we know that first you have to know that blood go to the spleen and get out from the spleen, go to the spleen, get out from the spleen. If sickle cell don't let the blood to get out, what would happen? It will going to go down to the spleen, and spleen will start collecting this blood, and there is a blood pressure on there, right? That helping the blood to go to the spleen. And spleen could be big, and we call it splenomegaly. When this will happen, his spleen will start breaking down the red blood cell, and he can gradually drop his hemoglobin and hematocrit. And sometimes even it could be very severe, like say if you collect 2 liters of blood in the spleen, and person can develop hypotension, and in this case we have to remove the spleen. And person sickle cell disease patient can suddenly also hit blood hemoglobin hematocrit can go down. If a person has sickle cell disease and he is infected with parvovirus B19, so virus name is parvovirus B19, parvovirus B19 infected patient can develop aplastic anemia, so his hemoglobin hematocrit can suddenly decrease. This person has hemolytic anemia, and he is producing red blood cell. His reticulocyte is going high to give the compensation. This person can develop folic acid deficiency. If this person has a folic acid deficiency, this person can suddenly drop, his red blood cell can suddenly drop. So we have sickle cell disease, he have a symptom, is not necessary, his hemoglobin will go down. And if this person has sickle cell disease, he has a hemolysis going on, same time he has a glucose 6-phosphate dehydrogenase deficiency, or person has acute splenic sequestration, this person hemoglobin hematocrit gradually can go down. And if this person infected with parvovirus B19, he can develop aplastic anemia, or this person has folic acid deficiency, this person red blood cell hemoglobin hematocrit suddenly go down. So sickleate red blood cell, main thing is blocked microcirculation. Sickle cell, it cannot go through the, for example, capillary, this kind of thing. It can occlude this, and tissue become hypoxic, and tissue become atrophic because due to lack of nutrition, and lactic acid can go high, and he can develop painful crisis. So now let's talk about the clinical presentation. And clinical presentation depend on how bad is the hypoxia going on the organ. And how bad is the sickling going on? We already know that normal cell become, when it become patient become hypoxic, dehydrated, fever, and all these things, that normal cell becomes sickle cell, and this sickle cell is the responsible to occlude the blood vessel. So we already talked that sickle cell disease is a autosomal recessive disease, and it's a genetics problem. So newborn, we have to know, newborn is more prone to develop the sickle cell disease when how old they will be. This is the important to talk on here, because we know that every newborn normally is normal due to he has hemoglobin F, and hemoglobin F, when it will be replaced with hemoglobin S, which usually start around the age of 4 months, then the infant start developing the symptom of the sickle cell disease. So for example, like the newborn, the infant around the age of 6 months, the infant develop the initial symptom of the swollen and painful extremity. We call it dactylitis. So it's the important to know the dactylitis. Most of the infant usually develop painful crises around the age of 6 months, and their hand and feet is the first organ to develop this swollen and become painful before other organ will be affected. So we call is hand-foot syndrome. So I will go a lot of things repeat again. So you just repeat again, you listen same thing again, and you some people even just listen 2 times my lecture, they are done. Some smart people will be like this, and they don't need anything else. Probably they will directly go to solve the question, and they will see they will doing well in the question, and they are ready for the exam. So swollen hand and foot extremity, we call it dactylitis, and we also call it hand-foot syndrome. So this is the initial symptom. A lot of time USMLE will ask this question, initial symptom, and you have to ask the hand-foot syndrome or dactylitis. And it happened due to the vaso-occlusion in sickle cell anemia. And 6 months to rest of the life, when patient become hypoxic, dehydrated, has infection which cause fever, puffiness, poor feeding, sickle red blood cell block the small blood vessel, patient could have vaso-occlusive painful crisis in the extremity. So this patient could have chronic leg ulcer, because blood vessel is blocked, nutrition can go down, and the organ is not getting nutrition, and without nutrition it will be start dying, and it will show the ulcer at the leg or extremity. And so painful crisis when sickle cell block the blood vessel. It can have painful crisis at the extremity, back, rib, chest, abdomen, thigh, knee, and same time patient could have low-grade fever. When patient has painful crisis, we already talked, he could have a fever, the person has very severe pain, he could have anxiety, he could have that, and that anxiety is causing him to have a tachycardia, dyspnea, muscle pain. So anxiety is behind here to person have tachycardia, dyspnea, muscle pain. Muscle pain happen due to the occlusion of the blood vessel, and so here not tachycardia, dyspnea here necessarily is not due to the person has anemia. So talk about the very important to know about the hand-foot syndrome. So what is the pathophysiology of it? It can cause the avascular necrosis of the metacarpal metatarsal bone in hand-foot syndrome. And if we do the X-ray, we will find the osteolytic lesion. And for example, person could have avascular necrosis at the femoral head. We call it hand-foot syndrome. This is the first two, hand and foot is the first two organ usually to develop sickle cell, and the ischemia cause the osteolytic lesion and osteonecrosis can happen. So these go to the extremity. What about the skin of the extremity? We already know that blood vessel is occluded by the sickle red blood cell. Nutrition is not available, so we can see the ulcer in the leg and hand, and due to hypoxia, due to lack of nutrition. And this thing sickle cell can cause the symmetric painful swelling of the feet and hand, and we call it hand-foot syndrome, also called dactylitis. So what is the effect of the sickle cell in the kidney? It can affect the kidney. Blood vessel is occluded, and it can harm the renal tubule. So renal has a problem in concentration of the urine, and this patient in the future can develop membranoproliferative glomerulonephritis or end-stage renal disease. And if we do the analysis of the urine of a patient of sickle cell disease, we will see red blood cell cast, and because sickle cell harm the kidney, and his bionin, creatinine would be high, and when not enough nutrition will go to the kidney, and due to sickle cell, and this sickle cell disease patient, his papillary will be necrotic, and that can cause this patient to have chronic kidney damage. What about the eye? Eye blood vessel can be affected. Person can develop retinopathy. When develop retinopathy, that can lead the patient to have blindness. And we already talked a little bit about how sickle cell affect the spleen. So repeated infarction of the spleen can happen when red blood cell becomes sickle, and when it happens repeatedly, not only the spleen, lung also can be affected, and this is happened due to the constant clumping of the sickle cell. All is sickle cell blocking the red blood cell, the blood vessel. So spleen could be atrophy, we call it orthosplenectomy. Lungs could be atrophy. And when spleen infarct, usually the sickle cell disease patient, when they are 6 months to 5 year old, they can have a spleen who cannot do its job properly. We call the functional asplenia. So when this happens, we already know a lot of places we talk about it. Patient could develop bacterial infection from the encapsulated bacteria. So what is encapsulated bacteria? We know that Streptococcus pneumonia, Haemophilus influenza, Neisseria meningitis, those are encapsulated bacteria, because antibody need to work against them and have to bring down in the spleen to do its job. When spleen is not working, then these people can develop infection from it. And in this case, when person spleen is atrophic, we have to give him prophylactic antibiotic and also vaccine for all of this, particularly the pneumococci, Haemophilus influenza. And pneumococci is the most of the time, because of his young kids, his immune system is not working properly yet, and he have more prone to get infection from the pneumococci. And pneumococci is one of the microorganism can cause the sepsis. And when kids without spleen, this pneumococci is most of the time can cause the sepsis. When sepsis will happen, and person can develop hypotension, his white blood cell will be elevated very high, his new neutrophil, we call the band of neutrophil, will increase. He is producing a lot of neutrophil to fight against the pneumococci, and he's have hypotension that can cause his alteration of the mental status change. He can have drowsiness, he can have high grade fever, he can have chill, and that itself, when person have a fever, it itself can stimulate the disc-shaped red blood cell to become sickle red blood cell. So sepsis make the painful crisis even worse. So we must have to deal with it very severely and very aggressively, because as long as he has infection, he has hypertension, all will be cause his red blood cell to become sickle, and the condition will become worse. So we have to give this patient and the vaccine for Streptococcus pneumonia. We call the conjugated capsular polysaccharide vaccine with the sickle cell disease patient should receive vaccination with a conjugated capsular polysaccharide, and we have to give this infant penicillin twice a day until he will reach 5 year of age, to prevent the sepsis And sepsis, most of the time when person develops sepsis, it can lead to death. So let's talk little more about the how the sickle red blood cell called the acute splenic engorgement. We also call it splenic sequestration. So sickle red blood cell cause the vaso-occlusion, and that cause, when, like I will talk about before, blood come in the spleen and get out. When blood vessel is occluded, it cannot get out. It start storing up the blood in the spleen. So when blood cannot get out from the spleen, only it can come. So it can cause the pooling red blood cell in the spleen. We call it sequestration. It separates the red blood cell from the system. This patient red blood cell would drop because blood is not in the system, blood is in the spleen. So his hemoglobin could go down, and person develop hypoxia, and that can cause erythropoietin to increase, and that can cause increased production of the reticulocyte. And in the peripheral blood smear, we also see that he has increased amount of reticulocyte. So when blood will be in the spleen, blood will destroy this red blood cell, and we call it extravascular hemolysis. So two places extravascular hemolysis can happen, one in the liver, another is in the spleen. And if he collect too much of the blood, he can even develop the hypotensive shock, because blood volume go down. That can cause hypotension. When hypotension can happen, different organ cannot reach any nutrition. That can cause the shock, and from the shock, even the person can die. Low blood pressure, blood is not going to the brain, and blood is not going to the heart tissue. That can cause a stroke, and that can cause show the pain at the heart, ischemia at the heart. Then we'll talk about this, when this happened, what happened to the heart in the cardiology. So when red blood cell will block the blood vessel of the spleen and blood cannot go out, this person, his spleen can rapidly become enlarged. And to prevent the shock, we need to take the spleen out, or as long as this spleen will be there, it will collect the blood, it can even rupture, and it can give the shock. So again, the sickle cell at the spleen cause the macrovascular obstruction, and this can result in fibrosis without giving the enlarged spleen, and it can cause the infection at the spleen. It happens around the age of 18 to 36 months of life, and we call the autoinfection of the spleen. So what happened to a patient of a sickle cell disease in the liver? Patient could have constantly sickleed red blood cell, and it could cause chronic hemolysis. We know that when red blood cell break down in the artery, it can increase the indirect bilirubin. That can come to the liver, and then bile will be produced, and when bile will be produced, it can cause the gallstone and the gallbladder. Anytime hemolysis going on in the blood vessel, bilirubin production will be increased, bile production will be increased, that can cause the gallstone and the gallbladder. And what about the salmonella? We know that sickle cell disease has prone to infect with the salmonella. Where sickle cell disease patient could develop osteomyelitis and septic joint, usually occur by gram-negative organisms such as salmonella to the single bone due to poor splenic function, and patient bone could be infected. Aseptic necrosis of the femoral head can happen, and salmonella also can cause the septicemia, and it can cause also sepsis. So salmonella is the #1 cause for sickle cell disease patient to develop osteomyelitis and septic joint syndrome. And Staphylococcus aureus also can cause the osteomyelitis, septic joint, but salmonella is the most common. When patient has osteomyelitis, patient could have fever, patient could have joint bone tenderness, and so these two most of the time can cause the osteomyelitis, septic joint. But streptococcal pneumonia and Neisseria meningitis, hemophilia influenza, usually these three organisms does not infect the bone, so these three usually don't cause the osteomyelitis, septic joint. So salmonella is the #1 cause to the osteomyelitis, septic joint, and Streptococcus aureus also can cause the osteomyelitis, septic joint. And in normal people, easily Streptococcus aureus is the #1 cause of the osteomyelitis and septic joint. So when this happens, osteomyelitis and septic joint patient can have aseptic necrosis to the femoral head or humeral head caused by vaso-occlusion by the sickle red blood cell. So person sickle cell disease patient has a sickle red blood cell. It could occlude the blood vessel, and it can cause the aseptic necrosis of the, without infection, it can cause the aseptic necrosis to the femoral head or humeral head. It can happen due to the sickle cell occlude the blood vessel.
Call from 93141311418.
And the adult patient with sickle cell anemia could develop the osteonecrosis. We call it avascular necrosis, a vaso-occlusive disease. So sickle cell occlude the blood vessel, and bone is not getting the nutrition. It can cause the osteonecrosis to the hip due to red cell sickle, which lead the microinfection and bone hyperplasia. Femoral humeral head are the common location for the osteonecrosis. Again, femoral and humeral head are the common location for the osteonecrosis to the patient of a sickle cell disease. When patient develop osteonecrosis, patient could have problem to move his hip, and for example he has restriction to do abduction, internal rotation of the hip, and he has only movement problem, but if you palpate the joint it will not cause any pain, and so he will not show any pain, but he has a necrotic femoral head or humeral head. He would have problem to do the movement of the hip joint, or and when kids have this problem going on and is chronic thing is going on, any chronic disease, know that it can cause the growth retardation. So what about if a mother of sickle cell disease become pregnant, and if she develops sickle red blood cell, her fetus will not get nutrition. She could have infected placenta that could lead her to have a spontaneous abortion, and even the infant, the fetus will be developed to the mature, but due to the insult, mother developing sickle red blood cell, it was blocking the blood vessel, and poor nutrition the fetus got. So in this case fetus could born with low birth weight. Because of the sickling of the red blood cell, older patient could have myocardial infarction, cardiomyopathy, stroke, transient ischemic attack, neurological abnormality. When then old people can have it, give him packed red blood cell. This will dilute the sickle red blood cell. Old patient would be infarction at the prostate plexus, which can lead to the priapism. What is priapism? He will have erected penis. In this case, we try to give him packed red blood cell to dilute the sickle red blood cell, and person could develop a stroke. And how it happened in the blood vessel at the brain, still it is unknown, but the theory could be like sickle red blood cell, when stick to the epithelial cell of the blood vessel, may activate the bone Willebrand factor, and when coagulation factor will increase, it can cause the coagulation, and when this person have a coagulation, he can develop a stroke, and he can have paralysis of the one side of the body. And any sickle cell disease people, any age people, can develop a stroke. And he will show the symptom related to the stroke. For example, suddenly you found even 2-year-old child, he used to walk, run, now he cannot do it anymore, and because of the stroke, and he could have clumsy hand due to the stroke. So what about the physical exam? We already talked about the spleen. If he have start sequestration of blood. He could have spleen go big, and he can develop splenomegaly. And the sickle cell disease patient also can have sickle cell when block the blood vessel, and it can cause the infarction of the spleen, and in fact the spleen size can become smaller. When this happens, spleen no longer is functioning properly, encapsulated bacteria will cause the infection. And we already talked, this person should be take all kind of vaccine, and he should be on penicillin for twice a day. And if we look at his, because hand and feet is the first symptom to give us hints that person has sickle cell disease. Like say 8-month-old came to the clinics, and he has swollen hand and feet, and we can also see there is ulceration of his extremity. We already mentioned why he will have ulcer, because sickle acid block the blood vessel, and tissue become hypoxic, and his skin become ulcerated. Person could have fever. If he have a red blood cell breakdown, hemoglobin go down, he can have anemia, and the symptom of the anemia, he could have pallor and pale color skin. And when red blood cell break down, he could develop his indirect bilirubin could increase, which can lead to have jaundice. So you will see the yellow color skin because iron stored in the skin or in the sclera of the eye. If patient have severe anemia, he could have systolic murmur, and when it will be go on like this, and he will his cardiac output will increase, and because too much blood is coming and in the heart, and heart have to pump lot of blood in the same time. If it go like this, person could have big heart, and finally he could have heart failure. And when person have anxiety, what person can have tachycardia, and when person sequestered to lot of blood in the spleen, and it can give the hypotension. So what is the diagnosis we will do? If we know that in any anemic patient, we could do the hemoglobin hematocrit. Here sickle cell disease patient can develop anemia, but without developing anemia, patient also can have symptom. So hemoglobin hematocrit value is not necessarily very important to know, but if person show the symptom, better to know in the peripheral smear, does he have any sickle cell. This is most important. But this person could be normal hemoglobin hematocrit, could be he have low hemoglobin hematocrit, or hemoglobin hematocrit even will be very low, depend on the situation. Anytime person develop hand-foot syndrome, like say 8-month-old kids, and we found he has sickleed red blood cell, next step we have to do the hemoglobin electrophoresis. So here hemoglobin hematocrit is not important. First he has a symptom, hand-foot syndrome, his family history has sickle cell disease, and we are thinking person could have sickle cell disease, and he is a young 8 month old kids have this problem with family history. We do the peripheral smear of the blood, we found sickle cell disease. Next thing we have to do to know the hemoglobin, we have to do the hemoglobin electrophoresis, and if we found hemoglobin A is 0%, hemoglobin S is 85 to 95%, hemoglobin F is 5 to 10%, and his hemoglobin S is very high. This gives us hints he has sickle cell disease. For a normal person, if we do the hemoglobin electrophoresis, we will find his hemoglobin A will be 99%, hemoglobin S will be 0%, hemoglobin F will be less than 1%. So if this person is breaking down red blood cell in the artery or in the spleen, and person has aplastic anemia, same person also have glucose phosphate dehydrogenase deficiency, person has folic acid deficiency. In this case, his hemoglobin hematocrit could be low, and this is happen when red blood cell breakdown in the spleen or bone marrow or the liver. We call it extravascular hemolysis, and in this case blood cell count will be low. So anytime the patient come, mother brought his, like say 8-month-old child who has swelling in the hand and feet, and you ask for this family history, you found some of the cousin or brother also have the same problem, you are thinking he has a sickle cell disease, you take the blood and you do the peripheral blood smear, and you found he has a sickle red blood cell, and next thing to do electrophoresis. So we already talked about in hemolysis, it can be gradual or it can be sudden. Gradually happen when person has glucose phosphate dehydrogenase deficiency, and person is sequestration of the spleen, blood, hemoglobin hematocrit gradually will go down. Suddenly will drop the hemoglobin hematocrit when person has infected with the parvovirus B19, or person has folic acid deficiency. Suddenly his hemoglobin hematocrit could go down. And anytime he has anemia, we know the hemoglobin hematocrit is low. Next time we have to do mean corpuscular volume for person with sickle cell disease. If he does not have folic acid deficiency, or he is not breaking down a lot of red blood cell at the system, and he is not losing the iron, his mean corpuscular volume will be 80 to 100, and he could, because he is breaking down red blood cell, if it be going on, reticulocyte will increase. It gives us hints that he is breaking down red blood cell, or somehow he is losing blood. As a compensation, his reticulocyte will be high, and when we see the reticulocyte is high, we are thinking hemolysis is going on, and we have to think that patient also could have glucose 6-phosphate dehydrogenase deficiency or acute splenic sequestration. Or these two cases, his reticulocyte will be high. When you will see the reticulocyte is low, we have to find out, we do have to think that he has aplastic anemia, and or he has a folic acid deficiency which cause his reticulocyte count is low. So person has anemia, his hemoglobin, he has a symptom, he is a pallor. Even in sickle cell disease, we know that hemoglobin hematocrit most of the time is in normal range, but he can also develop hemoglobin hematocrit will be go down. In this case, if he, after we know that hemoglobin hematocrit is low, we do the mean corpuscular volume, and it could become normal, or it could be decrease, or it could be increase depending on the situation. And same time we will do the reticulocyte. This reticulocyte count when will be high, we have to make sure we can come to the conclusion probably person has splenic sequestration, or he could have glucose phosphate dehydrogenase deficiency. If reticulocyte count below the normal, we have to think that he could have aplastic anemia, or he could have folic acid deficiency. And the same time we could see his mean corpuscular volume could be greater than 100. And sickle cell disease doesn't affect the GI tract, so patient with sickle cell disease usually don't show the symptom of vitamin B12 deficiency. So again, person 8-month-old, for example, came with swelling of the head, hand and foot, because the hand foot syndrome. The next step we have to do to examine the peripheral blood smear, and we will find the sickle red blood cell, and he would have reticulocytosis. And if we breaking down red blood cell in the blood vessel, and like say sickle red blood cell block the blood vessel, and the red blood cell is going through this blocked thing, it can itself cause the mechanical destruction of the red blood cell. When this happens, his total bilirubin will increase, his indirect bilirubin will increase, and patient can develop the biliary gallstone in the gallbladder, and he could through the gallbladder symptom. And so anytime destruction of the red blood cell in the blood vessel, he could develop indirect bilirubin. And again, to confirm the diagnosis, after no peripheral smear has sickle red blood cell, do the hemoglobin electrophoresis, and it will help us to find the patient has hemoglobinopathy, and it also give us hints, is this person has a trait or disease. One gene is deleted or both gene is deleted. If we take the blood from the system of a person of sickle cell disease, and we put in a glass slide and put it under the microscope, and we will see the sickle red blood cell. We can see the Howell Jolly body. What is Howell Jolly body? Is it And then when reticulocyte has a nucleus, what we call a Hall-Jolly body, usually red blood cell doesn't have nucleus. This when red blood cell produce in the bone marrow, it go to the spleen take out the nucleus, and it become a disc-shaped red blood cell. But when there is no functional spleen, the half the nucleus will be there, and we found the when we find the nucleus, we call the Hall-Jolly body. And this is the nuclear remnant of the red blood cell, which is supposed to remove by the spleen. But infarcted spleen cannot remove the nuclear remnant of the red blood cell. So we could see Hall-Jolly body in the peripheral blood smear, and this is the nuclear remnant of the red blood cell. When Hall-Jolly body will be found at the peripheral smear, and we should be considered that the child is in risk to develop the infection from the encapsulated organism such as pneumococci, Haemophilus influenza, and the meningitis, Neisseria meningitis. And in this case, we will not see any cystocyte because red blood cell is not breaking down. So the child with sickle cell disease, usually we will see the Hall-Jolly body around the age of 3 years. So within the 3 years, he will have autoinfarction of the spleen. Spleen will be non-functional, and around the age of 3 we could expect to see the Hall-Jolly body. And when we will see this one, and it will give us a red signal that this child is going to develop infection from the pneumococci. But if there is no Hall-Jolly body, give us hints that the spleen is not completely infarcted. So we already talked that he could have kidney problem, and he has a problem to concentrate the urine. His nephron is not working properly, sickle cell disease. So if we do the urine analysis, what we will see? We will see the red blood cell, we could see the protein, because he has a leaky glomerulus. And if we do the X-ray, person came with hand-foot swelling, we call the hand-foot syndrome. If we do the X-ray at the hand and foot, we can see the soft tissue swelling. And this person has, we already talked, that developed the indirect bilirubin, and he has more prone to develop gallstone and the gallbladder. So if we do the ultrasound test of the gallbladder, we may see the gallstone. So very important to talk about, if a sickle cell disease patient has a fever, and what is the next thing we have to do? Anytime have a fever, think person is infected with the pneumococci, unless it is proven by other way, and person is going to develop sepsis. So we have to do the blood test, and we have to do the culture of the blood, and we have to do the chest X-ray and then look for infection at the lung from the pneumococci and Haemophilus influenza, and we have to know you have to rule out that patient does not have sepsis. The history of sickle cell disease: patient has a fever, rule out, take aggressively that he doesn't have sepsis. To do this sepsis, to the blood, draw the blood, do the blood culture, and most of the case streptococci pneumonia can infect the lung, so do the chest x-ray to find that he doesn't have lobar pneumonia, and aggressively we have to rule out that patient does not have sepsis. So it's not like the child has sickle cell disease and he will show the symptom in 8 months or 9 months. And child initially may not show any symptom due to vaso-occlusion. And after some time, he could show the symptom of the sickle cell anemia. So when he will have some kind of hints, first we have to know peripheral smear has any sickling. If we find the sickling, then we have to do the electrophoresis, and then let's say in 2 months, 2-year-old or 3-year-old child now starts showing the sickle cell disease. Before, he doesn't have any symptom. He was not diagnosed for sickle cell disease. He is a 3-year-old now. What do we have to do? Peripheral smear, electrophoresis. We have to look at how his kidney is doing, how his bone is doing. We have to do the x-ray in the bone. We have to do the urine analysis. We have to look for any Howell jelly body, because it is very important. When patient will show the Howell jelly body, you have to take it aggressively. Give him a vaccine, give him prophylactic penicillin to prevent the sepsis. Because anytime anyone develop sepsis, death rate go high. So how we will treat this patient? In this case, we have to must know which one to give when have pain, when does not have pain. Well, I will talk in the bottom about it. So in sickle cell disease, prevention of the sickle cell pain crisis, or patient has sickle cell pain crisis, what is it? What is the prevention? Not to let the guy to become hypoxia, not to become dehydrated, not to develop fever. If we prevent this, because this can trigger the person has disc-shaped red blood cell to become a sickle red blood cell. So we have to prevent those surrounding around the patient. So when person has a pain, and what we should do, we should give this patient enough fluid. We can give him for manage the pain opioid analgesic, because it can give the anxiety can cause a tachycardia, this kind of thing. We can give him oxygen, we can give him rest. So when person has a pain due to sickle cell disease, this is the initial thing we can do: give him enough fluid, opioid, oxygen, and give him rest. if this person is like say in 1 year he has 6-7 episodes, he is frequently developing vaso-occlusive pain, what we should do next? We try to give him hydroxyurea. So hydroxyurea, what is it? It is a cytotoxic agent. It can increase the hemoglobin F by stimulating erythropoiesis in primitive erythroid precursor. When hemoglobin F will be increased, then it will decrease the probability, because hemoglobin F is not behind to give the sickling of the red blood cell. Hemoglobin S does. So if we increase the hemoglobin F and you can keep the percentage of the hemoglobin is down, we can prevent the sickling, and that can reduce the vaso-occlusion episode and decrease the pain crisis by diluting the sickle cell. If we give the hydroxyurea, we found that we are able to prevent his chronic pain. And what is the next step we should do? We give him erythropoietin. So let's see, hydroxyurea is producing hemoglobin F, and erythropoietin will help to produce more hemoglobin F. That the way we may prevent to develop another pain crisis. But what is the side effect of the hydroxyurea? It can suppress the bone marrow. When it will be suppress the bone marrow, patient could have anemia, patient could have leukopenia, patient could have thrombocytopenia. So hydroxyurea can cause the pancytopenia. So anytime patient has a fever, we have to be thinking person is going to develop sepsis. Right away we have to give him ceftriaxone or cefotaxime or levofloxacin or moxifloxacin, and sin without fever give him antibiotic, without know what is causing him to have a fever, without know the does he have any infection or not, because this patient could have non-functional spleen, which cause the increased risk to have infection. So the fever, right away give him antibiotic. If the fever is greater than 104, without giving orally, giving him IV ceftriaxone. Fever greater than 104, right away give him IV ceftriaxone. And patient with sickle cell disease, he has hemolytic anemia could happen, and in this case his reticulocyte is increasing just mean as a compensation his red blood cell is producing higher than normal, and in this case we have to give him folic acid supplement to prevent the aplastic crisis. And how alveolar body is increased, we have to give him 2 times penicillin and recommend him to take it 2 times a day. When patient develop infection from the bone, infection from the parvovirus B19, and he develop aplastic anemia, and we can think to do the bone marrow transplantation. So let's talk about when we will give him blood. What we give hints before. When we will do the transfuse blood, when we will do the exchange transfusion of the blood. Like say for a patient has priapism, acute chest syndrome, cerebrovascular accident, stroke, shock from the splenic sequestration, aplastic crisis due to the vaso-occlusion. When this happens, give this person oxygen, give him fluid, and we give the transfusion of the blood as the initial treatment. Know the person has sickle cell disease and he has this painful crisis. Give him oxygen, give him fluid, transfuse blood. Then look for the what is causing the crisis. If patient has vaso-occlusion crisis like priapism, stroke, uncontrolled pain, visual problem, acute chest syndrome, in this case we can give him oxygen, give him fluid, give him and same time we have to do the exchange transfusion because we are suspecting he has too many of the sickle red blood cell. If we do the exchange transfusion, take the blood out and the food blood bag normal blood bag to decrease percentage of the sickle red blood cell. The person also could have occurred due to slushing occlusion of the cerebral vasculature. Okay, if exchange transfusion does not work, we found he has a severe symptom, we take blood out, we give him new blood, and still we see it doesn't work, and we have to do the next thing, surgery to take the block out. So anytime we know that anytime we will transfuse blood to someone, we could think that he could have iron toxicity. To prevent this, we can give you deferoxamine as a chelation agent to reduce the transfusion related hemosiderosis. We already know that patient could have osteonecrosis in the femoral head or humeral head, and patient could have pain or no pain but have a problem in movement, and in this case when patient has osteonecrosis, if he has a pain, we will give him pain medicine, and same time we will tell him not to carry the load on the affected hip or hand. If this treatment management does not work, then we have to do the surgery to joint reconstruction. So again, splenic autoinfection can increase the possibility that person could be infected with the encapsulated bacteria, which is very important to know as a medical student, and which may cause the encapsulated bacteria after the infection. It can cause sepsis, and when have a sepsis, death rate would increase. So anytime patient has infection, we have to give him right away antibiotic. Before do the antibiotic, we have to draw the blood, we have to do the culture, and then we have to give the antibiotic. And anytime whole jelly body will be seen in the peripheral blood smear, we have to give him a pneumococcal vaccine, and we have to feed him in penicillin twice a day, and this we have to do until he will reach 5 year old, and if we do it, we can prevent the sepsis from the encapsulated bacteria. So complication from the infection. What? Sickle cell disease patient can have infection. He can have infection from the salmonella. Salmonella can cause the osteomyelitis, joint problem, sepsis, meningitis, even death could occur. And parvovirus can cause the aplastic anemia. Folic acid also can cause the folic acid deficiency also can lead to the severe anemia. Suddenly his hematocrit can go down. So I am just going to read my note one time of this part. It is not very important, but you have this because you already know this thing in step 1. And sickle cell disease is a point mutation of the beta globin gene cause the irreversible sickling of the red blood cell. The sickled red blood cell break down at the periphery and the spleen, so patient develop anemia. This anemia is due to sickle crisis. Body try to produce more red blood cell, like reticulocyte will be high as per physiological demand for the body. Folic acid need to produce the red blood cell. So if the patient would not take supplement on the folic acid, patient will have deficiency of the folic acid. Result of it, patient would have megaloblastic anemia, and patient could have generalized weakness, fatigue, dyspnea due to the anemia. After the age of 2 years, you would find the Hematology body at the body all the time, but sickle cell would be found when patient exposed to the situation to have sickle cell. So sickle cell will be on and off. When Hematology body will be in the system, it will be remain there. So helmet cell would be found when cell breakdown at the blood vessel, which does not occur all the time. Helmet cell usually would be found if patient has thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, disseminated intravascular coagulation that cause the blood vessel partially. When red blood cell will go through this, and it will break down the red blood cell. Same way sickle red blood cell, when it will block the blood cell partially, it can cause the breakdown of the red blood cell, and in this case we can find the schistocyte in the peripheral blood smear. And we talked before that non-traumatic cause of aseptic necrosis, like say necrosis at the femoral head. We know the sickle cell disease do. What other thing can cause it? If a person is alcoholic, person is steroid, person has Gossard disease, person has SLE, systemic lupus erythematosus. All of them can give the aseptic necrosis, and we call it non-traumatic cause of the aseptic necrosis. Like I said, it can happen in femoral head, it can happen in humeral head. So this is for USMLE Step 2 CK Hematology Part 10. If you know all of this, this will be probably enough for you to do well in USMLE Step 2 CK. So our next topic will be continue of the sickle cell disease.